Think of it from the mental health perspective. If you think about for every one person with schizophrenia, there's one person with Parkinson's. So how many people do you know with schizophrenia? We're a little bit skewed because we work in mental health. But on the outside, people don't really know that many people with schizophrenia, but they might know somebody with Parkinson's. In our world, we know about 100, but we don't know that many with Parkinson's. Parkinson's usually hits men more than women. It usually starts at the age of 60. There's an early onset, and we consider that to be under 50 years old. And there are some family patterns. It does not have to be genetic, but you do see it run in families, and we're not sure why. There are some genes associated with it, but nothing strong like you will see with Huntington's. In terms of epidemiology, who gets it? Where does it come from? How does it come on? Back in the day, farmers who were exposed to pesticides, especially paraquat, had 150% likelihood that they were going to come down with Parkinson's. This pesticide has since been discontinued in the United States, and it was very big out in Bangladesh and India, and it's been taken from there too. So the Parkinson's rate to farmers has fallen considerably. Those people that worked with heavy metals like lead, copper, or iron, or solvents like benzene are more at risk. In the Motor City, it's the people that worked in the car factories. That's why in part of the social history and occupational history is very important, because you want to know what have they been exposed to. I remember my dad worked for GM. He worked in one of the factories, and he had to get blood testing on a pretty regular basis. Then he got a different job and he didn't. So I kept asking, why did they do that? And he said, oh, they wanted to make sure I'm not going to get something and come back and sue them. I was like, well, okay. But I remember that General Motors is very big about testing for heavy metals in blood. Sometimes you get random cases. You have a family of 50 people and only one has Parkinson's. It's due to abnormal clumping of alpha-synuclein protein in the brain. These proteins are structural. They're supposed to be the supports for the cells. They don't clump like they don't stand tall like they're supposed to. They start to clump and wiggle, and eventually they just make a mess. And then that doesn't help the cells clean out what they need to of their waste products. The things build up, and as they build up in the cell, the neurons die off because there's no room for them. So that's on a molecular level what happens. We are seeing Parkinson's and head injuries, and professional athletes that are in contact sports. When I give the lecture to the residents about this, I have a video of Muhammad Ali, who is at the Olympic torch, and he's lighting the Olympic torch, and he is holding on to that torch to light it. And I think he needed help towards the end. But you can see that with lots of head injuries. So the mechanism I mentioned is that alpha-synuclein protein starts to clump up, and that means the substantia nigra in the brain deteriorates. So as you get clumped up, your cells literally explode. It's called apoptosis, and all the junk just floats around. It gets cleaned up by other things eventually. But you see here on the screen, the normal one, that brownish black spot, that's the normal substantial nigra. But you see on the right, the Parkinson's, how much is that dopamine? Dopamine dyes black when you dye it on a slide. So the dopamine has gone down considerably because there's not enough neurons that contain the dopamine. What happens is to conduct a message, you've got your presynaptic neuron, your synapse, and your postsynaptic neuron. So what's happening is the presynaptic neuron can't pass the message downstream. So this is the beauty of the carbidopa levodopa medicine that we have, and I'll explain that in a second. But you need to know the presynaptic neurons die off. So for anybody who has to take boards on a regular basis, this is on the boards all the time. So what kind of symptoms would you see in somebody who has Parkinson's? Understand that there is a wide variability. Not everybody gets every symptom. Not everybody has every symptom in the order they're supposed to have it. Sometimes they have a really great symptom now and it kind of fades and a new one pops up. But usually the symptoms are pretty stable, but just so there's variability. There's the three branches that we look at for symptoms: motor, internally, and psychiatric. So the motor is the stuff you can usually see just by looking at them. They have a hand tremor, which I'll show you a video of in just a minute. They have a shuffling gait. So if you get too far ahead of them in the walk to the office, you will hear them shuffling like they're wearing slippers. You can also see it too. That's why they've got to watch their step over transitions from carpet to tile and vice versa, because they will shuffle right into that piece that divides the carpet and the tile, that metal strip, and that's what trips them up. So they will shuffle to that level. A fenestrating gait means that the more they walk, the faster they get. The faster they get, the more unstable they get. They cannot help this. So they end up usually falling at the end unless somebody can catch them. Their speech does this too. They talk at a pretty average pace. The more they talk, the faster they get. I have a gentleman on the phone because he can't do video, and it's very clear how fast his speech can get the more he talks. So what we end up doing is communicating big items through my chart because he can type just as well as anybody else. But he has even noticed on the phone when he's trying to talk to me, he can't. He starts off very paced, and he's watching it because he knows he's on the phone with me, and then it just takes off into tripping over himself, and then he can't stop. A stooped posture looks exactly like that, like they're hunched over. That helps them lead to falls too because their center of gravity is off balance. The masked face is one of the most characteristic things you'll see with Parkinson's. It's because they look like they have no expression. We had a neighbor who had Parkinson's, and I always asked my dad, why doesn't he smile at us? He waves to us, but he never smiles. And my dad says, well, he's smiling on the inside. So that's what I have to remember with our Parkinson patients. They have the vocal inflection. You can tell if they're sad, you can tell if they're happy, but their face is not going to look like it. They have balance issues and lots of falls. There are a lot of strategies for balance issues and falls, but so that's how some people's Parkinson's start, is they just start falling, or they don't feel as sure on their feet, or they say, my gait's not steady, and then they get a medicine for Parkinson's, and all of a sudden they're walking a lot better. They may not have any of the other symptoms. So since Parkinson's affects all of your muscles, internally, you'll hear the vocal cords get lower and softer as the disease progresses. There's shaking and internal shaking, they'll tell you, because you see the shake on the outside. A lot of people do the pill rolling tremor, but a lot of people have a bigger tremor. They're shaking on the inside too. They can tell you it feels like my stomach's quivering. They have swallowing issues and choking. And this is one of the things we assess for every visit, because if they can't swallow their pills, we have to do something different. If they can't swallow their food or their saliva, something's got to give. We have to help them. The muscles that control swallowing become weak. Drooling for that same reason, as they can't control their own secretions. Dizziness is a very complicated symptom because it has to do with the balance, it has to do with the vestibular system, it has to do with the visual centers, it has to do with the side effects of all of our medications. So a lot of patients will tell us that they're dizzy, but how? So that's where we have to do a little more digging on that one. Constipation is one of the most common and most terrible side effects of Parkinson's, because everything's slowing down. Their gut is slowing down. It's not moving like it should, so the food is getting stuck. The feces are getting stuck. I've had so many patients that have been in the hospital for bowel obstruction, for impaction, things like that. So when I prescribe medications, I have to make sure that constipation is not going to be a side effect. And if it is, how are we going to manage it? So as I mentioned earlier, psychiatric symptoms are going to be 90% of our patients' issues. They come up with delusions, like their wife is not their wife, this is not their house, that the guy in the corner is out to get them, all kinds of stuff that you hear in schizophrenia. And that's where people start with the late life schizophrenia diagnosis, which is not true. So you have to be careful to take everything into account. Sometimes those delusions are part of Alzheimer's. So that's a big thing, is what else is there besides delusions? Hallucinations are very prominent. Most of them start off as visual, and they'll say it seems like a shadow or a bug. And they can get you a full-on party in the house with people and children and singing and dancing, almost like the scene from Home Alone, where he's got the cardboard cutouts and the people in the house to keep the robbers away. They can see that. I once had a patient invite her entire family to the carnival down the street. Her entire family came over, and there was no carnival. So that is the extent that the hallucinations can be real. There's anxiety. Is it the anxiety from constantly moving, that constant shaking inside and outside? Is it what is the disease process going to do? Who's going to take care of my family? And what's going to happen to me? Depression hits about 50% of our patients. And that depression is not the usual depression we see in younger folks. It's not the sadness, lack of sleep, sleep too much, anhedonia. It's the geriatric depression of, am I a burden to others? I feel hopeless, I feel helpless, I feel guilty that other people have to take care of me, I'm a burden to my loved ones. And the depression in Parkinson's is directly caused by the brain changes to the substantia nigra and to the relay centers in the brain. Because the Parkinson's, while it starts with the substantia nigra, it can spread into the relay centers too. So messages getting from point A to point B are going to be impacted. Depression of this sort doesn't respond as well as it does to the SSRIs in our younger population. So it's a very different depression. Many people with Parkinson's end up with memory deficits if they live long enough. And is it because of the Parkinson's, or is it because they live long enough? Or is it side effects of our medications? So again, we look into all of that. Insomnia is terrible. Insomnia they can develop before their Parkinson's or REM sleep behavior disorder. That's when they're acting out their dreams and kicking out and yelling out in the night. That can come 20 years before the Parkinson's diagnosis. Once they get diagnosed with Parkinson's, their sleep is fractured, it's disrupted, they're yelling out. They have to go to the bathroom, but they can't because they're stuck in bed. They're worrying. And then again, just with the brain changes that Parkinson's brings, you get the insomnia. On the flip side, you get sleepiness. They're not sleeping at night, so they're sleeping during the day is what we would think. And that's not how it runs. It's the medications, it's the disease process, it's the absolute sucking of all available energy that makes them so tired. So this is just a visual of what you can see in somebody with their symptoms. You've got the tremor, usually starts on one side. You've got the rigidity, so they're stiff, their posture is stiff, everything is stiff. The akinesia is a loss of impairment of voluntary and motor control, so they go to do something and they can't do it. Posture and balance is a big thing. So let me show you real quick a video of how the tremor looks like. So this, can you see, hold on a second, probably not. There it is, okay. Okay, can you see my YouTube? Okay, so this is what the tremor starts off at. It's very mild. Some people would not even notice. Let me show you that again. Let me mute this guy. So, come back here. Oh, where did my tremor go? I'm sorry, I had it. Where are you, tremor? I'm sorry, I had it. Okay, dang it. I hope you had it. I hope you saw it real quick. I'll find it again. But it's very, very innocuous. It's very mild. Some people don't notice it. Some people it will be pointed out to them by somebody else. And then they say, oh, you do that thing. Is you have a nervous tic? Do you have something? You know, so that's when they usually end up at the doctor, is to get that taken care of. Step back. So what can you do? There are surgical interventions for this, and that's usually at the end result when medications don't work anymore. The deep brain stimulator puts electrodes right into the substantia nigra. That's usually where it goes. And then they're fed through a pacemaker right above their chest. And it really does look like a pacemaker. Sometimes now, it used to be pretty big. Now it's about as big as maybe a quarter of a deck of cards. It's very flat now too, so you can barely notice it. But if you look for it, you can find it. So there's one that's a deep brain stimulator awake form. That's what they use for essential tremor. And essential tremor is completely different. Essential tremor does run in families. It does have different medications, but it too can interfere with function. It doesn't cause all of the other things that Parkinson's can cause though. Another most major form of treatment is the carbidopa-levodopa enteral suspension surgical intervention. Nobody in the world calls it this. They all call it by the brand name Duopa. So you will never hear of it called the enteral suspension surgical intervention. It's Duopa, which is the brand name from the manufacturer. And at the right-hand corner, you see it's like a PEG tube, and it's got hooked to a monitor. It gets into the GI system directly. That port needs to be flushed regularly, so you have to have somebody who's able to cognitively care for that. So sometimes people can use that one cassette. It's a little jelly thing. You put it there. It can last up to 16 hours. Some people use 2 a day though, because you've got to do stuff 24 hours a day. So sometimes what our patients in the morning would tell us, the mornings are the worst because I literally cannot get out of bed. So this pump primes it. So in the morning, you get more of the medicine that you need to move. So you can get up out of bed more easily. And then the rest of the day is a continuous, like a drip almost. You can have an extra dose because sometimes people they turn off, and I'll explain that in a second. They turn off when now you need to move. You can't just sit here all day. So they push it and they get an extra release. This is good for people who don't qualify for the DBS or they don't want to do it this way. So how does this usually run? This usually runs that motor symptoms start, and it starts with adjustment symptoms. So it starts with what's going to happen to me. I know so-and-so has Parkinson's and I saw them decline quite rapidly. I know Michael J. Fox has been around forever. He's got Parkinson's. He's a totally different story. So you get the motor symptoms, and then you get the behavioral, the memory symptoms, and then you get the behavioral issues. And it's pretty linear in Parkinson's. When you get towards the end of the disease process, you get what's called a fluctuating consciousness. So their good days are really good, their bad days are really bad. You can see just the course of the day that their temperament changes from morning to afternoon to nighttime to bedtime. There is an overlap with Lewy body dementia. It's a similar disease process with the alpha-synuclein, but it tends to spread out all over the brain. Whereas Parkinson's, the alpha-synuclein localizes first in the substantia nigra. People who have Lewy body dementia, which is a whole separate conference, they have the motor symptoms, but they have some memory symptoms. But hang on a second, they've got some hallucinations. Well, no, what about this now? They've got depression, but the carbidopa levodopa we use isn't working for the motor. So by the time law enforcement gets involved, that's my clue to diagnosis that something is wrong. Because the Lewy body dementia patients don't have enough memory impairment that they have more care. So they will call the police for their visual hallucinations of guys sitting out in the car out front. So when law enforcement gets involved, that's usually the time I realize, oh, hey, it's probably Lewy body. Substance abuse is a big problem in Parkinson's patients as well as their caregivers. So we need to be on the lookout for that too. So how long can you live with Parkinson's? You can live quite a long time. You see on the left of the screen, the initial symptom of 20 years until the time of diagnosis is constipation. The people who have chronic constipation, are they going to get Parkinson's? Maybe, maybe not. We don't know. Do they just have chronic constipation or is it the prodrome? But on this screen, it says 10 years for RBD, REM sleep behavior disorder. REM sleep behavior disorder can come 10 to 20 years before the diagnosis. But then some people will tell me, I was diagnosed in 2017, but I think about 2014, 15, I lost my taste and smell. So this is pre-COVID, so that's important to know. When did they lose their taste and smell? Because that's another random thing that can happen in Parkinson's. Then as the years go on, they tend to be slow, they tend to be stooped, they tend to have a tremor. And then they start developing more internal symptoms with urinary problems, orthostatic hypotension, swallowing, more falls, and then psychosis starts to ramp up later in life. One of the biggest things that Parkinson's patients deal with is called the off period. And the off period is literally just that they are shut off. They feel like the Tin Man in The Wizard of Oz before he gets his oil. The neighbor I was talking about used to have a sense of denial about his Parkinson's. That he would go out and mow the lawn. And my dad was retired at the time. We were good friends. So my dad would go sit on the porch at our house and wait because he could hear. My dad has excellent hearing. He could hear down the street when the lawnmower did something funny. He would take off running. And there is our neighbor sprawled face down on the ground with the lawnmower going. And he said if that he ever falls backwards and pulls the lawnmower on him, he's in big trouble. So my dad would go down, pick him up, and he said, this is in the late 80s before we had really good medication. And he would pick him up, put him in the lawn chair, call his wife and tell on him, get him his medication, and then a couple minutes later, he could actually see him starting to move again. After that, the neighbor's wife asked my dad if he would cut the lawn for them instead. So then the neighbor would sit in the chair and watch my dad. But it happened often enough that my dad knew what to look for, and my dad has no medical training whatsoever. So the off period can be very scary. I've had it on the video once where one of my patients said, "Oh no, here it comes." They have a sense of dread, they have a sense of doom, something is not right. And after a while, they learn that it's the off period coming, but in the beginning, they don't know. Is it a panic attack? Like, what's going on? Am I losing my mind? I can't move. I don't feel good. I think I'm going to fall. And one of my patients said, "Oh no, it's coming." I said, "Well, what do we do?" She goes, "We just wait." So we just waited. She could still talk, but I could see that she was not very comfortable. I said, "Do you need me to call somebody?" She goes, No, this happens all the time around this time. I'll just sit through it." And as time passed and her medication kicked in, she was able to move again. So they're terrifying for us to watch. They're terrifying for the patients when they begin, but they're not something that needs medical attention, as if they were to have a seizure or something. So just talk with them, sit with them. It happens in the office. It happens at the worst, most inconvenient times of their life. And it's deathly embarrassing to them. It happens at church. It happens at weddings. Anytime where there could be something really happy going on, they have to have an off period, and it's not psychological. It's 100% biological. So what do we do for our patients? Our Parkinson's patients take a number of medications, and they cycle through them. You will hear patients say that they tried carbidopa levodopa, which is the standard of care. Carbidopa levodopa is wonderful because it goes right to that postsynaptic neuron to keep the messages going. And I can't remember which is it. One is carbidopa, I believe, is the active medication, but your body gobbles it up, and all these other enzymes process it. So the levodopa is a trickster, and it pretends to be carbidopa, so it distracts the other enzymes so the carbidopa can actually do its job. So you'll see people that have tried that. Most people take that 3 or 4 times a day. And it's a tapering process where they start like a half a pill a couple times and go up to a whole pill. So they keep working their way up on that. The side effect of the carbidopa levodopa is dyskinesia. If you do it too fast or you overdose. So instead of freezing or having being slow, they look like they're wiggling in the chair. They're going from side to side in their screen. They have more risk of falls there because they're not stable. Another of the big side effects with carbidopa levodopa is hallucinations. So people will tell you, I had my medicine adjusted, and ever since then, these clowns are in here. I can't get them out. The police won't come get them. My wife says they're not real. They're not. They're a hallucination. So the key to that is just to dial back the medicine. That's the easiest thing to do. And then go slower on the up to get them there. Amantadine is an antiviral medication from the first flu epidemic we had where we could actually use medications. It has some actions on the motor systems that can help people move better. It doesn't work very long. It doesn't work very powerfully. If carbidopa levodopa is 85, amantadine is probably 35%. Some people respond really well, some people not at all. Estradiol, which I can't even say, selegiline, apomorphine, rotigotine patches, they all work on different parts of the motor system to help. They won't do the direct targeting like the carbidopa levodopa, but they try to augment in other ways. Carbidopa levodopa comes in a bunch of different formulations. So there's the immediate release that people will take if they're frozen. There is an extended release that they can use to carry throughout the day. A lot of my patients take an extended release at night so they can get out of bed in the morning. Some of them take 3 or 4 formulations of the same medication. So that's why it gets really complicated. But it helps. It's like the one thing that can help until you can get to VES. And then, of course, with 90% of them having mental health needs, we have our psychiatric medications. We have the usual SSRIs, we've got the atypical antipsychotics. Conventional antipsychotics like haloperidol have more muscle blocking. If you know that one of the biggest side effects for haloperidol, stelazine, all of those guys is Parkinsonism, where they look shuffled, like they look stooped, they look like they have a mess space, they look like they have shuffling gait, but it's all due to the medication. When you see somebody on long-term conventional antipsychotic use versus somebody with Parkinson's, you can see that there's a difference the more you see them. But if you only see them a couple times each, you really can't tell. So we go for the atypical antipsychotics because they have less dopamine motor blocking than the others. That being said, I've used haloperidol 0.25 milligrams in Parkinson's patients just fine, where my patients in schizophrenia are taking 20 or 30 milligrams. So the doses are very different. Buspirone is great for anxiety. The older you are, the better it works. Mirtazapine, venlafaxine. Mirtazapine plus venlafaxine is a combination called California rocket fuel. It targets so many different systems within the brain that it can tackle the depression that comes from having Parkinson's because of the brain changes of Parkinson's. Tricyclic antidepressants we usually stay away from because they're very constipating. But sometimes I have people who had depression 40 years ago and did really well on a medicine called amitriptyline. Well, amitriptyline starts at 50 milligrams for the general population. For somebody with Parkinson's, I would start with 10, just see how is 10 milligrams for you. And then there's pimavanserin, which is known as Nuplazid in the brand name. It was designed to tackle the visual hallucinations directly, because if you think about it, we needed something, because the medications for schizophrenia just can cause more trouble. My personal opinion is this doesn't work as well as it was sold. I think it's oversold and overpromised, but some people can get some benefit from it, so we don't write it off completely. And then, as I mentioned earlier, Parkinson's patients start having memory issues. And we use our usual memory medications that we would for people with Alzheimer's. Interestingly, donepezil, which is most commonly known as Aricept, is to help preserve memory. But in Parkinson's, it can treat visual hallucinations, depression, and anxiety. Again, that's because the Parkinson's brain is so complex. Sometimes donepezil is the one medication that everything else gets consolidated into and goes away from. So it can do a lot of good. Sometimes people take that and it's not because they have memory issues, it's because I have tried everything else for hallucination and mood, and this is my last resort. So they may not have memory issues, they may be taking it for other reasons. Rivastigmine, galantamine, memantine, those are also what we use for memory preservation. They don't have the added benefits of mood enhancement though. So other modalities that we use to help a Parkinson's patient is the deep brain stimulation I mentioned earlier. Speech and swallowing evaluations are invaluable. The people that do these have come up with the most amazing tricks to help our patients eat and swallow and drink. Again, this is important because the number 1 and 2 leading causes of death in people with Parkinson's is falls and pneumonia. Pneumonia is because they can't cough anymore like they used to. They can't clear their secretions, so they end up backing up into their lungs. And that's why we need to make sure they can swallow. Every January, and I'm getting ready for it, every January I lose about 2 or 3 Parkinson's patients a week from pneumonia. So that's why the swallowing is so important. Physical therapy is incredible. They help so much with the gait, they help so much with the balance. They have special Parkinson's physical therapy programs. One of them is called Rock Steady Boxing. And I can tell you everybody, this is like an N equals everybody, whoever goes through that program comes out better. If you put what you want into it, you get what you get out. The people are so much better with that. They've actually had their doses of medication reduced. If I can't get somebody to go to physical therapy, I will sell that you may come down on your medications if you go to this instead. Big and Loud is a speech therapy that they help with the vocal cords, because the vocal cords get weaker and weaker, and this helps them stay on top of things. I have a patient who used to be a radio announcer in another country, and I told him this. I said, look, you have a radio announcer voice, you have to keep it. So he went to Big and Loud. He said he could feel it coming back and getting stronger again. Occupational therapy is very helpful for the home and for the tremors. Patients with tremors have a lot of trouble eating soup, eating anything after a while, because they shake so much they can't get whatever they want to their mouth. Or if they're holding a glass and it doesn't have a lid or a straw on it, it's all over. So occupational therapy has come up with weighted silverware. So if you pick it up, it's heavy. It can like do some damage if you throw it at somebody or if you throw it out a window, because it is that heavy. But because it weighs the hand down so much, the hand can't shake, they can get their food to their mouth a lot better, and they're very grateful. That is covered by insurance. Insurance will pay for that. So ask them, do you need weighted silverware? Anybody can order it. I've ordered it 1,000,000 times. So they get very clever and creative. So with Parkinson's, this is where they're going to come and see you. They're going to come and see me for medications, and I'm going to say you need to have a therapist because we can't do this on our own. The biggest frustrations and concerns that Parkinson's patients have is the loss of health. with the internet and TV and everything else in the world, they can see other people with Parkinson's and they all think they're good. They all think worst case scenario. They think the worst case of Parkinson's they ever see is exactly how they're going to end up. It doesn't have to be the case, but they see that their health is changing. It's not going to be the same. They have a loss of independence. As they go on with the disease process, they need more and more help just to do their ADLs. Some of them can't drive anymore. We don't want them driving. So we'll do the Secretary of State forms for an evaluation that says this person should not be driving, and the Secretary of State be the bad guy that takes the license. So then Michigan, we have the public transportation. So that's equivalent to chopping off their legs. So now you're really not going anywhere, as when you don't have a driver's license. So the loss of independence in the house and jobs and all of that too. Some people fear they're going to lose their job. And if they lose their job on the grounds that they have Parkinson's, that's discriminatory, and that is a sure win lawsuit, because you can't discriminate somebody on their disease or physical disabilities. But some people feel that if they go to work with these symptoms, they're going to get made fun of, which is true. They're not going to be understood. People are going to ostracize them because, again, they're different and it's physically different. So they worry about that. Sometimes people's symptoms become so severe, so rapidly, they have to stop working. And then that starts a medical disability, mourning, grief, and loss kind of work, where you were great on Monday and now you're not on Tuesday. That's a big life change that you need to process. The loss of relationships has been a very interesting one. Many of my patient spouses are supportive. I would say 95% of them are supportive. The 5% say, stop shaking. You're making this up. Why can't they fix you? All kinds of terrible things. I have had patients get divorced, not from their choice, but get divorced because their spouse said, I don't want to take care of you. That's terrible. I mean, when most marital vows say in sickness and health, I'm like, well, this is the in sickness part you signed up for. They don't want it. Their friends start backing off because they don't understand what they're going through, or with the delusions, they've accused somebody of doing something and they don't want to be around for that. On the flip side, I've seen some really meaningful relationships come out of this too. So it's not only a loss of relationships, but definitely a changing of relationships. The other frustration with Parkinson's is always changing. For anybody who's been pregnant, each week to week is a different week. So today is week 5 of pregnancy. It's nowhere near week 20. That's kind of how Parkinson's is. It's month to month, a new symptom pops up. I was good for this long and now I've got this. So they're constantly changing and the medications are constantly changing. Some people fear that they're going to develop Lewy body dementia later in life. And this is a very valid fear because they can have a Lewy body picture later in life, but is it Lewy body? Is it end stage Parkinson's? We don't know, because clinically they all look the same, and on autopsy, they look the same. So that's why we treat symptomatically. So in this sort of situation, this is best addressed with interpersonal therapy for grief and loss or role transitions. This is great because interpersonal therapy is time limited. You've got your 12 sessions. You can always extend it if you need to, and they will be back as the disease changes. But processing the grief and loss of I was healthy, now I'm not. I had a job, now I don't. I was able to do all these things for myself, now I can't. Role transitions, and I was a caregiver, I was the breadwinner, now I'm not. Now two people are taking care of me. That is a big, huge deal for men that were born between 1930 and 1980. If they were taken out of their breadwinning role too soon, you're going to hear all about it because now they're worthless. Now they're useless to the family. I'm more dead than I'm alive. They've said all this stuff to me before. And one guy, I actually said, well, how much is your life insurance? He told me. I said, how much is your pension? How much is your VA pension? How much is your Social Security? So how much are you pulling in a month? I said, so if you have a life expectancy of 20 years and you're making X number of dollars a year just on your pensions, you're not worth more dead than alive. So just sometimes just talking like that and pulling out the numbers is really helpful because they're at their wits' end because now they can't provide. And so role transition time, you provided the income, you provided the health insurance. You guys are all set now. You don't have to worry about that. Now you can provide companionship. Now you can provide babysitting for your grandkids. Now you can provide other things. So trying to get them to think outside of their head sometimes is helpful. Another thing is medication works great, and then it doesn't. I have so many people that say my carbidopa, levodopa worked forever, and now it's not working anymore. It feels like I'm not taking anything. I need to get back to the neurologist. The deep brain stimulation helps too, for quite a long time. But as time goes by and they get older, the motor symptoms return, and you get the hallucinations. These are happening because the brain is changing. Your brain is always changing. It's either progressing or regressing. And as you get older, it's more likely regressing. So those symptoms, are they coming up just because of aging, or is it the advancement of disease, or what? But I've had the original, because I do geriatric psychiatry, I have had the original deep brain stimulator patients. And now they look no different than the end-stage Lewy body Parkinson's dementia patients. They tend to respond worse sometimes to some of the medications because I'm getting interference from the DBS. So I've asked some of them to shut the DBS off so we can do other things with medication. But the DBS, I had a good video, Julia probably does, where you turn the DBS on, you can see them stop. They just stop moving, they stop shaking. They can play their violins again. They're all on YouTube. So if you ever look up Parkinson's on YouTube, you get a lot of really cool videos. Another frustration is some people have insight into their changes and some people do not. That just goes with any disease process. You have the caregivers who refuse to accept the changes and treat the patient as if nothing was wrong, which is terrible because we need help here. Or you have the people who distance themselves. The patient or the caregiver is so stressed out that they're using substances. This is why we screen each and every time for the changes. Because they're early in the disease process, they're still trying to figure it out, they're not touching the alcohol. But a couple of months in, we've got another problem. Legal issues come up. Some of them have to close down their business. Some people are in need of legal guardianship. Some people need conservatorship now. So those come up. Fear of placement. Everybody has told me at one point or another, I'm just going to end up in a nursing home. Do you think I need assisted living? Well, you have a lot of options. Only 4% of Americans live in nursing homes. The chances of you living in a nursing home are actually very low. So when I tell them that, they are very reassured. It's only 4%. Could they go to assisted living? Could they afford it? Because those things are expensive, $5,000 a month sometimes. Or can they get in-home care? So that's when we work with the primary care doctors to see what level of care does this person need and how can they afford it. But my favor for you is please do not ever comment on their medication regimen. I had a therapist continually do this for my patients. I actually call it for them to please stop. We know that their medications are terrible. We know that they take a lot of them. We know that they have side effects. We know that they have drug interactions. Believe us, when we are doing these assessments, we're taking that all into account. Otherwise, we are not doing our jobs. So I have had a patient's therapist say, why do you need 2 antidepressants? Why do you have to take mirtazapine and Effexor? They're both antidepressants. That blows up my chart. That blows up my phone. So now I have to go back and reassure the patient that this is okay, as we talked about as your appointment. So now I just started telling her at the appointment, this is unusual because this is what we need to do. They do not work the same. They don't go to the same parts of the brain, but they are classified as antidepressants. And then I will point out, well, you take 2 blood pressure medications. How come you can take lisinopril and metoprolol? And then they say, oh, so part of that is stigma against psychiatric medications and psych patients. Some of it is general, just trying to be helpful and say, why do you take so many medications? Can't they clean this up for you? No. Not with Parkinson's. It's terrible. We try. We really, really try to keep the medications to a minimum. But because of the complexity of the disease, we can't. Hold on. So they already know they take a lot of medications. They're checking on those copays for those medications and telling me that some of them are too much. I have told patients, again, just to back up, when they take 2 depressive medicines, 2 anxiety medicines, 2 movement medicines, I tell them it's like oil and gasoline. They're both fluids for your car, but they work differently to make the car go. From your end, what is your role going to be here again too with this is reminding the patient that while this is a neurodegenerative and progressive disease, they can live a long life. And you're going to try to help preserve their quality of life. It can deteriorate over time, but you're going to try to help them preserve that. You're going to ride that unpredictability of disease progression with them. Today is great, next visit not so much. 5 visits ago, things were perfect. 5 visits from now, they're not. And you're going to learn how to make adaptations physically and mentally for them and with them. So you may be calling us asking for help, but this patient's got a new symptom of whatever it is. Whatever it is, you don't have to have a plan. You don't have to have an idea. Just call us and tell us we have more falls. The patient's been falling more. The patient is sleeping more. The wife says he's not eating. Whatever it is, there's something we can do to help. So please let us know. Most of the appointments in the beginning are probably going to be, what's happening to me? Why is this happening to me? And just trying to wrap their heads around that this is going on. So you may end up with repetitive questions in the first couple of visits. And then as you get processing it, it comes up again. But I still don't understand why this happened to me. We don't know. We wish we did. So from there, I'll pass it to Dr. Toledo to do Huntington's. I'll stop my screen share and then let her go from there.
Okay, bear with me. I just want to make sure I do this correctly. Thank you all for your attention. I don't know if we wanted to break up questions because Parkinson's was the majority of the information. But I think for now, if you do have one, I would just put it in the chat so that we can.
Yeah, I can get it because Quinn had a question.
Oh.
So addressing freezing of gait. So by addressing freezing of gait, since it is seen as a motor symptom, but there are behavioral interventions. What's the difference between shuffling of gait and freezing of gait and solutions? Okay, so shuffling gait, they're moving. They're moving, they're slowly, their feet are not picking up off the ground. So kind of like, imagine a toddler in high heels. You know, she can't walk across the floor, so she's gonna shuffle her feet as she goes, and you can hear it. The freezing of gait is a dead stop standstill. They look like they're frozen to the ground, but they will tell us that their feet feel like they're magnetized. They cannot pick up their feet and they're stuck there. So what you have to do for somebody who's stuck is stand there with them. Get as many people as you can, because if they start to waver, they're going to fall. That is an off period when they're standing. And it's terrible for everybody because you're worried they're going to fall. They're worried they're going to fall, and they are going to fall. But how can you make it so they don't get hurt when they do? Does that answer your question?
Yeah, thank you.
Mm-hmm. Okay, go ahead. I'm all set.
I'm trying to see, do you all see my screen or does it look weird?
I see you, and I see the thing in the middle. Hold on.
Can you see the slides?
I can see you now. Yep, if you click on shared content.
Oh, did I not do that?
I don't know. I can see you though.
You can see me, but can you see the
you were in the
video?
corner. No, you were in the corner and your screen, your slides are big.
Oh, okay. All right. I didn't want it to look kind of, what do you call that, disorganized. I had it open. That's why it kind of messed me up. Okay. Can you still see the side of it?
Yep.
Okay. So I didn't mean for it to look like that. Yep. All right. Oh my. I'm so sorry. Okay. All right. And so again, as Dr. Boore-Clor brought up, the reason why we're bringing up Huntington's disease, even though this is the Michigan Parkinson Foundation, is because it is a movement disorder. And some people have either heard of it or not, because it's a very, genetic based disease. It's different from Parkinson's in that sense, in the sense that we've already pinpointed a lot of the genes associated with it. Again, because it is a movement disorder, it is helpful to work with not just the neurology team, but, we handle, Dr. Boore-Clor and I, very similar sort of more of the mood and psychiatric symptoms. Okay, so as far as we know, there's about 30,000 Americans, usually later in their adulthood, although I have seen patients as young as in their 20s develop this illness, unfortunately. And again, so what we call genetic anticipation means that the more that you have, in the next line, repeats of a code defect, the more likely you're going to have the illness sooner. And as we have different generations of families, so like grandparents, parents, children, the likelihood of you having more repeats gets higher. They've done research trying to target treatment for this, and they're not totally sure what the Huntington protein does. And again, that's why there's genetic testing. you know, it's a complex thing for families to decide, you know, and for individuals to decide whether or not they want to have genetic testing. Often the role that I have is actually doing some of the evaluations for whether or not people should have genetic testing. And I can talk about that more in a bit, but I would highlight that sometimes this is the need for a therapist to work with some patients, because sometimes, for example, I won't clear somebody if their depression is severe. If they're having suicidal thoughts, I wouldn't want to have them, you know, go through understanding if they do or don't have this illness, depending on what they're thinking and what they're going through and what their support system is like. Okay, so let me see, hopefully it does this, but I had the videos already brought up, so hold on. Again, like, because this is not as common as Parkinson's, it's a little different. So we do have videos on here. I'll just bring them up. Okay. Can you all see it?
No, I can't see it. I can hear it. I can see you though.
Okay, let me see if it'll let me screen share. Sorry, I am a little technologically not great at this. I don't know how to change which screen I'm sharing. Let me try the link. How about now? Any better?
I still see you.
Oh, and now you can hear a commercial. Okay.
I see the screen, the Huntington disease video.
Oh, you do see the video?
I don't see the video. I see it says the link to it.
Oh,
Okay.
yeah. Okay.
Yeah, we
Yeah,
see
if
your
you-
slides. I think you need to stop sharing and then share the video.
Oh, okay.
Yes, just stop sharing the slides. Yeah.
Okay. Hold on. Give me a second. Sharing. And then open the video and then share. Okay.
Yeah.
Oops. That's fine. How about now? Better?
Yep, you got it. You got it.
Okay. So this is what it looks like.
Swanbury, how's your chair for you?
Lovely.
Lovely. What was your other chair like before?
Comfort.
Uh-huh. And you found that you would slide down the chair and fall?
Yeah.
Yeah?
All right. So that was one video, again, to sort of highlight what the movements look like. Again, it's different. We call them choreiform movements because some people almost describe it as like you're almost like dancing. That's like the way that that word came about. Like I think it's Latin origin. So these patients are unfortunately constantly moving, especially their limbs. I've had patients who in clinic, they've like if you put the chairs normally, like the way we do in most doctors' offices, they actually end up hitting their heads a lot because they're moving their head so much, and we have to kind of realize that and try to move them in a comfortable position. You know, and again, like a typical chair is sometimes comfortable, but sometimes it's not. You know, if you want to do an exam on the patient, you don't have them sit on an exam table, you just have them sit and be as comfortable as possible. The other thing, especially because we have a multidisciplinary clinic, which has, again, multiple disciplines, is sometimes, you know, they need time to kind of move or, you know, and they have to kind of take their time to move and to transfer. So sitting there and waiting. I have to credit our patients with the ability to sit there and wait through multiple, multiple teams talking to them while they're trying to, just stay and be patient with us. So let me see, I have another video I was going to share just really quick. To also highlight the fact that, unfortunately, it does have a 50% genetic inheritance. So the way I would think about that is, if you have two children, as you'll see in the video, unfortunately, there's like a 50-50 chance that your children will inherit this illness. So give me a second. Okay, sorry. Still slow with screen sharing again. Okay. I'm not going to show you the whole video, but just so you can see. I hate this. Sorry. And it all ready to go. Sorry.
We first found out HD was in our family, I think it was 3 years ago.
2006.
Was it? Are you sure? Wasn't that?
I think it was when I was about 5.
Yes. Maybe 4 years ago then. We weren't aware of HD before that point. The doctors think that Meg's dad must have had it, but he died in his early 50s.
Cancer.
Yeah. So really it was a complete shock to us. We didn't know anything about the disease before then. Obviously it's a very steep learning curve.
I didn't even know HD existed before I knew Mummy had it. I was quite young.
I don't think we've ever kept it from the girls. I mean, they were actually there at the time when Meg was diagnosed in the same room, and we've never, felt that we had to keep it from them. The first time we went to the Hampshire branch meeting of the HDA, we didn't take the girls because we weren't sure what we were going to, quite experience there. But from that point onwards, they've been to branch meetings, been to lots of social events, and obviously mixed with people with HD. So I don't think there was a conscious decision to tell them or not. It's just something that we're kind of grown up with since the day we found out, really.
We gave Flo we sent for some of the, a booklet that Flo read, didn't you?
Yeah.
And the branch explained it to children.
Yeah, I think our reaction straight away was to try and find out as much as we could about it. I know perhaps some people want to do the opposite, but we kind of felt we needed to know. And the kids all along have been part of that. There's never been a decision to keep anything from them.
Okay, I'm just going to, I can always add more to video or send, the link, but let me stop sharing. Okay, so again, you can kind of have a contrast between Parkinson's and Huntington's disease. I will say that actually sometimes people think they have Parkinson's, and then their diagnosis is different. Because it's 2 o'clock, we didn't know, does anyone want to take a short break before we keep going, or have any questions they want us to answer right now? I can keep going if you all want.
I think we're fine with going, and if somebody has to duck out, they can, but very interesting content, and great that you're looping this in under the movement disorders, which it is, so thank you.
Okay, let me go back to sharing my screen again. Okay, can you all see it again? Oh, just let me know if you can't. All right, so again, we can go over the symptoms, but you kind of saw them, which is, I think, more helpful in a way. So especially, actually, I wanted to add this in because it's a little different in a very virtual world to only see sometimes part of, you know, like right now, the floating head. This is the rest of someone's body, especially because much like Parkinson's, the degree of the present symptoms can go from, you know, not having any symptoms at this time to progressing actually within, I think, 10 years or 20 years even. So shorter than what we described in Parkinson's. But again, it's a little different for each patient. So you saw the large uncontrolled movements. So there's an overlap, you know, just so you know, of psychiatric medications that we use. Two of them are olanzapine and risperidone. And sometimes we choose those medications because there's an overlap of helping to treat some of the movements. And then also, unfortunately, patients can have mood disorders, so even manic behaviors and psychotic symptoms like hallucinations and delusions. And then there is cognitive impairment, especially as the disease progresses. So again, similar to Parkinson's, we might be using these medications like donepezil, which Dr. Boore-Clor mentioned, or memantine. And then as far as OCD, that's another unfortunate sort of behavioral change that it couldn't occur. And similar to OCD in the general population, we use SSRIs, so commonly things like sertraline, also called Zoloft, and then escitalopram, also called Lexapro. Like I have a patient who didn't have OCD, you know, on the earlier stages of the illness, but then later it progressed to where she could not leave the home without counting things. She would get extremely angry if anything was out of place. And in a way, it's actually really difficult for the family to continue to live with her, even though they need to be involved in her care. So some of these symptoms, again, similar to Parkinson's, but can cause distress for the caregivers as well as the patient. Irritability, again, sometimes actually that's on the spectrum of mania or hypomania. So we're treating, or anxiety. So we treat them with anxiety medications such as the SSRIs, as I mentioned, and buspirone, a medication that's traditionally FDA indicated for generalized anxiety disorder. And again, the psychotic symptoms, as I mentioned, we try first with usually the olanzapine and risperidone because of the overlap. Again, but as Dr. Boore-Clor alluded to, usually we would try other medications if these were not found to be effective. And drug and alcohol abuse are unfortunately sometimes part of the illness, and also a differential that we rule out. High risk for this, again, unfortunately. And before genetic testing, I often want to understand where somebody is, if there's some substance abuse, if they're getting treated, and whether or not they want to be involved in treatment as well. Actually, I've had patients also where the suspicion for Huntington's is not because they had a family member who had the movements. It actually was not the first thing that happened. It can sometimes be, you know, oh, they were diagnosed as bipolar with manic behaviors as the first sign of the illness. You know, I've had a patient tell me their father, you know, abused substances, the alcohol helped with shaking, and then unfortunately he passed away. And because he had been distant from them when he started becoming more and more ill, they didn't realize what was actually going on with him. And then only later, when they had some symptoms and hearing more about Huntington's disease, that they realized, oh wait, maybe that's what happened with him, but they had no idea when they were growing up. So again, we're going to review therapist goals. So again, there is this very big decision about whether or not you want to get testing. And I do think it's really up to the family to decide. I mean, it's such a big thing to know that you have a fatal illness and this is passed on to your family. and could be passed on, you know, to generations after you. And that's a big thing to know. And I think a lot of patients do or don't want to make that decision to know for themselves for the sake of their children, or they don't want it at all. You know, they're like, well, I think I have this illness. I've seen it in my other family members. I don't need to have like a genetic testing done. And again, it's a process to be evaluated for this. Most patients that we meet in the early stages, you know, they're seen by the neurologist, they're seen by a geneticist, and then actually, according to the HDSA, we usually want them to be for the standards under HDSA, and I think overall they want to be like psychiatrically or psychologically evaluated. So that's my role in the clinic also, is to do a psychiatric evaluation. In other clinics that may not have a psychiatrist embedded, they sometimes see a psychologist, but either way, it's our responsibility to decide, is this patient ready? Are they a good candidate to get such a serious test done? The other really, really significant issue is the risk of suicide. So the risk of suicide, knowing the test results, can be high. Having the illness, you know, untreated depression, for example, can also increase the risk for suicide, but we're also finding out that even before somebody gets to genetic testing, they are at increased risk for suicide. So it's very important that we understand where they're at, where their family's at, what support systems they have. And again, actually, I've had patients who they kind of understand, like they really want the testing, but they have the wherewithal to really realize, like, I'm not in a good place right now to find out these results. And again, that's the role sometimes that I have with therapists, is that, you know, with medication management and with therapy, we could get to a place where, okay, I feel like my depression is under better control. I have ways to cope with anxiety. I've built a support system that can understand what this illness is and what's going on. So then we might move forward with genetic testing instead. But even before that, it's so important that they have support all around, from like their medical team, their family, friends. And there is the HD support group. We don't have, at least right now, there's not a lot of therapists out there who really understand this illness. And I don't mean that, you know, in a negative way, but just from, I mean, all around the shortage of behavioral health, you know, specialists, all the way from the therapists to the physicians, is low. And this is such a specific population that it's, again, to have, I think it really helps to have an understanding of what the illness is, so that when you're talking to patients and interacting with them and their families, you are familiar with it, and that makes patients more comfortable talking about what's going on. Okay, so again, the planning ahead for understanding the results of the genetic testing, you know, a lot of people, the financial burden can be high. And so again, patients sometimes have to stop working like into their 40s, you know, or they didn't anticipate having to stop working so early, and needing so much assistance and care, needing medications, needing to follow up, needing to do things like physical and occupational therapy. So it can be extremely stressful, and this is extremely important, not just for themselves, but for their families. So this is something that it's not easy to talk about, but together I think it's really helpful to not just have doctors addressing this, but to have a therapist that they can work with as well. And as you all know, you know, there are a lot of people who don't want to say things in front of their families. And this is also an important outlet for them to be really able to talk about what's going on to somebody who can be objective. Okay. So we're going to switch gears and move to dystonia, because we're kind of rounding out the movement disorders.
Teresa, did we want to take a quick break?
Oh, do we?
Yeah, it's built into the schedule.
Okay, sorry, then I will stop sharing and yes.
Okay, so we'll take like a 5-10 minute break, come back about 2:20, 2:25.
Sounds good.
If anybody has any questions, you can put them in the chat, address some of them now.
In the meantime, I'll go ahead throughout the program and start sharing some of the links as well for the Michigan Parkinson's Foundation, the Huntington's Disease Society, and the Dystonia Medical Research Foundation. So, so that you have these resources available to share with your clients or patients.
So if you get a survey and you ask, is this presentation free of bias? It is not. It is not. We are so pro Michigan Parkinson's Foundation that we're not unbiased.
Well, thank you.
I wouldn't be here if we weren't. So.
Well, we appreciate it. I often say, you know, for my 24 years, I worked at Henry Ford in the Parkinson's clinic. I really didn't know all of the resources that the Michigan Parkinson's Foundation has to offer. And I'm shocked to have to say that because I did work very closely with them. But when I came here and I really learned about how many resources that we have available to patients and families around the state, sometimes it's quite staggering. So don't overlook us. We aren't going to find the cure. We're going to leave that to Michael J. Fox, but we're going to help support as you go through this journey. Are there any other questions that are coming up from the audience that you have in the meantime?
This is the place to ask. We are the least intimidating people out there. So
It's true.
we don't judge.
I get that from patients a lot, actually.
Two psychiatrists that don't judge. You love it.
Oh, it's hilarious. Dr. Boore, she listens so well. She never judges. Clinically, I am, but no. But I can ask her anything. I'm like, thank you for putting that right in the survey that goes to the CEO. So you can really ask us anything. Don't be shy about it because you need to know because you're going to get more and more people like this.
I agree, and I would hope that even if there's some therapists on today's program, that if this is something that you'd like to know more about or share with your colleagues, we are open to doing more programs. I told Dr. Boore-Clor, I think this is the #1 question we get at the foundation, is that they are looking for a Parkinson's specific therapist to deal with behavioral issues or mood issues or even marital issues, and there are not. And so it's our goal, and I feel obligation to get out there and educate a lot of the therapists throughout the state so we can better serve our patients.
So there's a question in the chat about, do the patients need to take Medicare or Medicaid? Do the therapists need to accept Medicare, Medicaid? I don't know. I've seen a lot of different insurances go through with the patients with therapy. Teresa, are your Huntington's patients, do they end up on Medicaid because they're so young?
Yes.
I want to say
I think so.
I think it's different. So something unique about the state of Michigan is that right now, like if you were to look at the way funding for medical care is, there's something about the separate funding for behavioral health and mental health. And it's not like this in every state, which is sometimes why we have patients in the neurology department that with their insurance can see myself or Dr. Boore-Clor, and then a neurologist that the billing is different. Like for some reason, they cannot be seen in behavioral health, but they could be seen through us. And unfortunately, I have had this come up where somebody was accidentally scheduled with, I think it was a limited licensed psychologist who had like a different insurance. And it was really sad because they had built a really good rapport in the first visit. And then they found out because of insurance, they couldn't continue their care together. And it was really, that's like a legislative issue. That doesn't have to do with one way or the other. So, and again, they're seeing me because the Department of Neurology. And again, it has to do with the way the funding is. So we don't really have a control over that, but we usually try to avoid, something like that from happening.
Yeah, I do think that it is legislative for sure. And my hope is that, at some point we'll actually get a candidate that's going to run about improving the mental health situation in this country, particularly in the state. And you are absolutely correct. In the state of Michigan, they have 2 branches of insurance: health insurance for medical, and then psychiatric for behavioral health. It's really, I think it's going to become a bigger problem, particularly on the other side of COVID. With stats like Dr. Boore-Clor mentioned about, how Parkinson's disease is on the incline significantly, throughout the country as well as the state. They predict it's going to double in the next couple of years. So I think it's going to be more of a problem. So I think we have to write to our House representatives and senators and anyone else that we can about how important this issue is.
Yeah, I work with actually our Michigan Psychiatric Society. So it's hard because there is a lot of changes that could occur. It's not always that people don't agree that there needs to be a change. It's a question of how that change is going to occur. Especially, again, COVID really, I could talk about this forever, but COVID really exposed a lot of problems with healthcare that are even bigger. And when I say healthcare, I'm not just talking again about nurses and doctors. I'm really talking about everyone. So that ranges from, therapists, medical assistants, nurses, doctors, like everybody across the board in the realm of healthcare. We've had losses, and it just seems like it keeps getting harder and harder to access care in some ways. So, yeah, I mean, advocacy is important. I'm sure that the Michigan Parkinson Foundation has ways, hopefully, to advocate for this, but I think it's almost more frustrating when somebody doesn't know what's going on, but then worse when we do and we don't know what to do.
I think I just had a bad idea. Does Michigan Parkinson's Foundation need 2 lobbyists? Because we've done lobbying. I've been in the Michigan Psychiatric Society a long time ago when I was younger. If you need lobbyists, you get them for free. So let us know.
I agree. I know that we do work a little bit with the Parkinson's Action Committee, which is, a national program, but we do need more representation in the state. So if anybody wants to join us, we would be happy to hear from you. We need it. We also need to change the laws about, in Michigan about giving medication on time in facilities and hospitals, because, what people don't seem to understand is that if they don't get their Parkinson's medication on time, you're making it harder to take care of them.
Yeah.
Why make your job harder?
Right.
So there was one question I was just going to address in terms of, do we have a list of therapists throughout the state that specialize in PD? No, we don't. That's the problem. There is no such thing. And that's what we really want to do is educate more therapists who are more familiar with Parkinson's disease. So with that, I think we can go ahead and get started again. Thanks everybody for your patience. Keep the questions coming, and I'll put more information in the chat bar.
Okay. And I think the next section is a little bit shorter.
Yep.
If I'm not too uncoordinated to do this. All right, so again, in the realm of movement disorders, there is a diagnosis called dystonia. Actually, this is very different from the other 2 illnesses in that sometimes it's not terribly obvious like what's going on. So a focal dystonia refers to the fact that it's only one part of the body that's affected. So if you look at these different terms on the screen. So for example, if we're working at something like cervical torticollis, well, this presents as cervical, so your neck, and it's often twisted. I have a patient who literally talks to me with her body facing one direction so that she can face the camera in a different direction. And then if you look, there's different kinds of dystonia, again, that can involve your eyes, that can involve your jaw, that can affect your speech. And it's hard because one of the, if you can imagine a muscle that is unable to be controlled the way that we think of our other muscles, it's actually often quite painful and can be extremely limiting and hard to understand. I would say that some of my patients really struggle with the fact that I would say of the illnesses we're discussing today, this might be one of the hardest ones to diagnose. And then there is a little phrase here that says psychogenic. So that is sort of, you all may be familiar with the term psychogenic being that there's something going on from a neurological standpoint, but it's not in the way that we think of it. The unfortunate thing, for example, is that some people think, well, you're making this up, or this is driven by you doing this on purpose. And because there's no way to genetically necessarily pinpoint like, oh, this is tied to this, and that's why you have these symptoms. Somebody can have a full-on battery of tests and have the symptoms and really not have a total diagnosis of what's going on, the same way that it occurs with Huntington's and Parkinson's disease patients. So again, psychogenic dystonia, they occur commonly out of stress, but it doesn't have to be. Again, one of the worst things I've ever seen is somebody being told that they're faking it, that they're doing it on purpose, and they're not usually at all. They just are misunderstood by families or even their treatment teams sometimes as wanting like, oh, why do you want this pain medication? Or again, I have another patient who's on Valium and people don't understand, or even I've worked with other doctors who, because they don't understand what's going on, and this diagnosis for some people isn't formally made, they don't understand why somebody would be taking that medication. So it can be really difficult for patients, cause a lot of anxiety, cause a lot of conflict when not just like maybe their families and friends, but also other members of their healthcare team don't understand what's going on. So this also speaks a bit to our role in the realm of behavioral health of what the treatment is. So again, physical and occupational therapy are very important. Rest and reducing stress. So patients who have an undue amount of anxiety, it just makes their symptoms worse. So they find themselves exhausted and, again, for different reasons, extremely anxious. So when we are helping to treat that anxiety, that depression, we're actually really helping to treat the dystonia as well. There's a lot of different forms of what we all know as Botox, but really getting at the muscles that are causing the dystonia. Sometimes this helps, but it doesn't last, the whole time. It's also unfortunately quite painful for insurance to get insurance approval for this. It's a whole procedure that sometimes patients don't always have a lot of access to. So that can be challenging as well. And again, cause a lot of the anxiety that we try to help them through. There are what we call anticholinergic medications that often do have side effects, especially with older patients that we don't want, but trihexyphenidyl is name is Artane. Sometimes there's the two names that they use. Deep brain stimulation is also used, again, something that takes a lot of effort and work to not only get the evaluations for it, to get approval for it, but then, following with surgery. But actually, this is a really great treatment that works really well for some patients and actually can result in decreased number of medications. And then on top of that, decreasing stress again, and actually, unfortunate for coffee lovers, reducing caffeine can also help when it comes to blepharospasm, which is the spasm in your eye, like a very specific dystonia as well. The Michigan Dystonia support groups, again, like I think we're really fortunate to be exposed to the fact that support groups, including the Michigan Parkinson Foundation, exists. And sometimes it is just a matter of connecting a patient with people that can help them, people that understand them, but also understanding that some patients are not ready or not interested in those kinds of treatment settings as well. And again, I can't emphasize enough that sometimes they want to talk to a therapist instead of a group. And it's hard because it's really difficult sometimes to find somebody who understands what they're physically going through. And again, we've talked about how there's multiple teams often with the movement disorder. So it's not just a neurologist, there are speech and swallowing evaluations, physical and occupational therapists are often very, very important. So again, going down to the therapist goals, there is, with any illness, it's hard when the family doesn't really understand what's going on, and that is the primary support team, primary support system of patients. The sense that you're not faking it. I've seen this happen even with other movement disorders, especially in the earlier stages where people, even the patient themselves doesn't understand or doesn't know what's going on. This is actually one of the illnesses on social media that I don't really want you to look up what it looks like. I think I'd rather you have a more reliable resource than YouTube, just because it's more subtle than like Huntington's disease. That's exactly, the video really portrayed what it looks like. I think more and more people are familiar with Parkinson's, not just Michael J. Fox, but other people who have been diagnosed and are willing to talk about their diagnosis. This is very different in that way. Managing the stress to lessen the dystonia. Again, we talked about that earlier. I have often, encountered patients who, because they also maybe have limited exposure to behavioral health, psychiatry, they don't really know how to manage stress. This might sound weird, but when they get more and more stressed out with different things that are affecting their lives, they have not really practiced anything like coping skills. Mindfulness has just become this buzzword that a lot of people use in society, in like pop culture. But I mean, these are all things that can help treat anxiety without being dependent on medications. Progressive muscle relaxation. Again, I'm sure that a lot of you know way more of these different coping skills and strategies that patients can learn, but there is a good amount of my patients who want to learn this, and I try to teach them, but I have 30 minutes with most of them just to get it started. And I think it's always good reinforcement for, as a psychiatrist, to have a therapist that really works together as a team. Yeah, I can't say that enough. So now we have the post-test. Dr. Boore-Clor, I didn't know if you wanted to take over this part.
Sure. Okay. So here, can you blow it up?
I can just leave the screen on.
You can leave that screen on. Can you just blow it up, hit F5?
Oh, sorry, I didn't realize it wasn't the blown up version this whole time. Oh no, I messed it up. Sorry. Sorry, 1 second. Or do you want to just share it on your end?
No, it's okay. I can just read it from there.
For some reason I can't make it. Oh wait, hold on. Sorry. Yeah.
Okay. So for the post test, now that we've done this, for number 1, which
now I can't hear you. I think you're muted.
How can I be muted? I don't think I am. Am I?
Can anyone else hear her? Did I mess it up again?
I can hear you.
I can hear it.
I can hear.
Okay.
So, okay. You know what? I'm just going to stop sharing and let you pull it up, if that's okay.
It's fine.
while you're doing that, Dr. Boore-Clor, I'll just say, if anybody noticed, I did put in the chat information regarding Michigan Parkinson's Foundation, Huntington's Disease Society of America, and the Dystonia Medical Research Foundation. All very good support programs, and also list any local programs that are in and around the area.
Okay, all set? Okay, so we'll do the post-test. And for the first question, which of the following symptoms are consistent with Parkinson's?
I was gonna say, I can't hear you still, Dr. Boore-Clor.
How can
Unless it's
they
just
can
me.
hear me?
It's totally possible.
I can hear you.
I can hear you.
No, I can't hear you. So, okay, that works. Which of the following symptoms are consistent with Parkinson's disease? Is it A, tremors, B, stooped posture, C, masked face, D, hallucinations, or E, all of the above? Okay, so that one should be E, it's all of the above. And number 2, which of the following symptoms are consistent with dystonia? Is it A, cramping with inability to move a specific area willfully? Is it B, involuntary movements of the arms or legs? C, memory loss, D, stomach upset, or E, the inability to run?
B.
So that's A. A, dystonia, like a torticollis or a writer's cramp. You can't move it. So if your hand is stuck, you're not going to get it done. Dystonia doesn't have memory loss with it. It's just purely muscle, but Parkinson's and Huntington's can, because they're brain motor. They're not just motor. Huntington's disease is a hereditary disease. That's true, unfortunately. Number 4, Huntington's has a life expectancy of 20 years after diagnosis. That's false. It's 3 to 5 years. 5, patients tend to struggle with emotional challenges that can be met by, or I should say met with, medications, psychotherapy, regular exercise, regular sleep, or E, all of the above. It's E, all of the above, because you need to have people on a regular schedule for regular sleep, regular exercise. Exercise is like the one cure-all for every body system. There's this book called The Biology of Aging, and it's older. It's like, I forget, it's like the 60s or 70s, and it's still very valid. Every single treatment option for each body system, whether it's skin or GI or brain or anything, is always exercise. So regular, consistent cardio exercise is one of the best things you can do. So now that we have a lot of time for questions, and again, please just ask away. We are, like I said, the least non-judgmental people. There really are no stupid questions because there are no stupid questions. But this is a new territory. We're trying to find people that can help our patients.
So
We have case scenarios up the wazoo. So we have those if you want some of those. What do we do in a certain situation? We've got it.
we have a question on here. Why can you clarify that number 2 is not B? So that was the dystonia question. So I guess the way that I would explain that is, I think in the question we were differentiating from involuntary movement. So that would be like we saw in the video with Korea. And in the way that the answer was, so dystonia is not just like your, how do I say this? It's not the same thing as like having, for example, a seizure where you can't, sorry, Dr. Boore-Clor, I would say it was more like, it's not that your muscle is kind of, when we say stuck and cramping, that doesn't mean that it's not like in motion. It's just actually kind of stuck versus like a more involuntary, bigger movement, or even Parkinson's tremor. It's not like a tremor. It's more like you're stuck. I can explain that. I don't know, Julia, if you want to, you look like you want to say something.
Okay. Yeah, because the dystonias are like the neck down. So they won't cause memory loss from the neck up. They don't start in the brain, they start down. The others are all generated in the brain first.
I would say I think that it's very confusing because a lot of the terms as well, orofacial dyskinesias or dystonias or cervical, or, there's so many different terms that I don't think that people actually are familiar with those definitions sometimes.
That's true.
Yeah, the reason why we're presenting on them in this one presentation is because they fall under the realm of movement disorders in the realm of neurology. So it's like a bigger branch. And then so neurology, movement disorders, and then the types of movement disorders. There are even more. We just went over some of the more common ones that we encounter. That definitely doesn't mean that these are the only ones. I will say something weird that happened recently in a clinical, sort of case is that I had a patient who was applying for disability who couldn't. The problem was their documentation didn't have it written a certain way. So it looked like we were all diagnosing a bunch of different disorders when it really was dystonia. So that's something that, again, the most important thing to me is always working together to really be clear about what exactly is going on and our treatment plans being similar or the same. Well, I mean, similar.
So we did have another question, maybe Dr. Boore-Clor, if you want to take this one. Is it common for late stage Parkinson's to show increased psychiatric symptoms acutely? So increased delusions and hallucinations, confusions, etc.
So that's a yes and no, mostly no. If it's overnight, within hours to days, no, that's not Parkinson's. That's delirium. That's a bladder infection. That's a medication mismatch. That is somebody messed up their meds, took too much, too little. It's pneumonia. It's a blood clot. It's some medical event that's actually a life-threatening emergency that needs to get evaluated right away. Once you clear up whatever that medical issue is that's underlying, all of those will kind of go back to just under their normal baseline. When people have a delirium where they have those altered mental status changes quickly, they look like it's crisis night in the ER, or they're just laying in bed, not interacting with people. So it's a hyperactive delirium for the first one, a hypoactive for delirium for the second one, both deadly if you don't find out what's going on. But when they recover from that, they never go back to where they were before. The more of those they have, the more they tend to decline. But Parkinson's itself, and then of course when you have dementia or chronic diseases and multiple medications, that risk of delirium goes up. But if you have somebody with Parkinson's in the later stages, they will rapidly progress, and this should be weeks. It should not be hours to days. It should be over weeks. We start seeing changes happening faster. And when the changes start happening faster, they stop swallowing, they stop eating, they're losing a ton of weight. That's when we just kind of hold off and call hospice and say we need some other ideas here, because the disease has now taken over and outsmarted our medication.
Yeah, not to mention that if you've seen one person with Parkinson's, you've seen one person with Parkinson's, because everybody is completely, it's a boutique disease, custom made for one person, right? Okay, so we have another question. Can you go over life expectancy again? I thought ALS was 3 to 5 years and Huntington's was 20.
So actually, I was trying to look at this as well. For Huntington's, I think because of the way we treat it, it's actually a little bit longer than 3 to 5 years. It's hard to say, because we were saying from the time of diagnosis. So often getting the diagnosis can be a process in itself. So sometimes people don't get diagnosed until much later. And, with ALS, Dr. Boore-Clor, I think it is shorter.
Sure, ALS is really short.
Yeah.
I'll look it up. But ALS, I think, is also 3 to 5 years.
Yeah, I think.
Yeah,
it depends on the progression of illness. Yeah,
I can't handle the shorter life expectancy diseases. That's why she does them. And I think ALS is a 3 to 5 one too.
Well, that's a weird thing to say about me, Dr. Boore-Clor.
No, but that's why I take the Parkinson patients. I'll take all the Parkinson patients. Then it's my own kind of transference. I have no family members with these conditions, but I just cannot do it. So that's why I mean.
Yeah, I don't mean to laugh. I'm a nervous laugher. I'll just be honest on here. But it's similar, and again, because with Huntington's, in a way, we kind of know the progression could be faster or slower because of the genetic testing, especially if you've had it done. So I think the range, and again, even actually with ALS, the lifespan is a little bit different than it was when we first started really understanding these diseases because of what we can do to help treat the symptoms nowadays.
Yeah, so
That's a good point. I was going to bring that up. Yeah.
yes. So according to one of the verifiable websites, 20% of people will live 5 years or more, 10 will live 10 years or more, 5 will live more than 20 years. I've never heard or seen or had a patient live more than 5 years. Usually from the time of diagnosis, you have 2 to 5 years. So you may have had symptoms before the time of diagnosis.
Yeah. And it's hard because these symptoms can be very subtle.
Yeah, ALS and Huntington's and Parkinson's kind of do this fenestrating end. The closer you get to the end, the more things speed up.
Yeah, and I was just going to mention that, you know, many of these patients with Parkinson's, many people come in, they were misdiagnosed. Oftentimes they'll say, oh, I thought I had MS, or, you know, and the familial component is so rare that you can't really kind of look at that as much with Huntington's disease, where it's so strong genetically. I think that, you know, many people just get misdiagnosed, or, you know, they just aren't in an area where you have specialists that really specialize in this area. So even when you were talking about psychogenic dystonia, which, you know, it's very common to hear people with dystonia who say, I've been to 5, 10 doctors. They all tell me it's in my head. And it isn't until, honestly, I think they get to a movement disorder neurologist who really does explain and break down what psychogenic dystonia is.
So again, like actually that's a really big part of the role of, again, not just a psychiatrist, but also a therapist, because sometimes they are, you know, even established patients can have this rapport with you, and you can kind of help them through the struggle of not knowing. I think that's one of the worst things. And I'll admit it, sometimes doctors are not great with the not knowing part, because there's a part of our med school training that tells us, like, we have to figure this out. If we don't know, it must be something else. We don't have a test to determine that, but actually a lot of our diagnosis is clinical. You know, it's not, we don't have as much testing in the world yet. It is being developed, things about imaging that can help us understand mental health disorders and psychiatric disorders. But I would say that actually the most painful thing is sometimes not knowing at all what's going on. You know, like they're like, I have a very subtle symptom, but I don't know what's going on. I had a man who was like always healthy, and all of a sudden he couldn't jog with his wife in the morning, and it was just very subtle. He's like, oh, I'm just getting older. And then he ended up having ALS, but he didn't know it. So, you know, it's sometimes it's like we try our best also. We might be catching somebody on a different end of the progression of illness. So having somebody just kind of understand what's going on with you that you can talk to, it's very, very important.
And every single one of these, oh, go ahead, Julia.
I was just going to ask if you could touch on it, because we were kind of talking about it before everybody got on. About dopamine agonists and, you know, people not being aware of some of the side effects that could cause some of these issues with Parkinson's.
Yeah, so for people that take the carbidopa levodopa, which is known as Sinemet in the regular world, too much of it is a good thing, because now you've got too much dopamine. So like in schizophrenia, when you have too much dopamine, you start seeing things and hearing things, you can get delusional. But then I've had patients who get the dyskinesias, so their bodies are like, kind of like what you saw with the Huntingtons, where they're all over. And they can be any body part, but I had patients that sit square in the middle of the screen with me like this for a video visit, one visit. And the next thing I know, they're going this way and that way, and they can't out of their seat. And I'm like, what are you? I'm like, did you take your medicine? What's going on? And they're trying to figure out, why did you just change in the span of a second? And or they'll tell me that. They'll tell me, I can't seem to sit still. I got this new medication from my neurologist, and they didn't follow the taper, because you take like a half a pill for a week, and you add in a half a pill the next week, and you build up to it. Some of them take the whole thing that they get right at the top. So everything's gone wild. Everything's distressing, and they're hallucinating. They can't sit still, and they call on me because, again, like we keep saying, with the least non-judgmental people you'll talk to about this, and we really are, because they know we're not going to make fun of them. and they'll say something's going on. So I ask them, well, how much are you taking? And they'll take me, oh, I'm taking 25/100. It's like one of the common doses for Cinemet. And I'll say, well, how often are you taking it? Oh, I take it 4 times a day. And I got the neurologist note, like, that's not what you're supposed to do. You're supposed to take a half 3 times a day and then work your way up. So it's simply stopping the medication and working that back and letting it settle for a couple of days will resolve that. Some patients, like our bipolar and manic patients, like to run just a little manic. They don't like to run a little depressed. They like just play and flirt with that danger of mania. Our Parkinson's patients will do that too with their Cinemet. They will play with that danger of dyskinesia because they move better. They move great when they take more, but they want to balance getting the hallucinations and the dyskinesias. And so sometimes that does happen.
And like with the dopamine agonist, when in terms of side effects with like, gambling and pornography and hoarding or collecting items, things like that, like oftentimes that really should be a conversation with the neurologist because it could be just the side effect from the medication.
Yes, I have a lot of Parkinson's patients that also carry a diagnosis of gambling disorder. They never gambled in their life, and for some, that's how it starts. All of a sudden, they start gambling, and they get this out of control gambling disorder, and they've got Parkinson's. So when we can get a better hold on that, the gambling does go down. Some of them get very sexually preoccupied too if they have too much Cinemet. That's dangerous to the family. So again, we have to scale that back, work that back. Sometimes we can't. So we'll use an SSRI to cause sexual dysfunction so then they can't be so active with their spouse who's just darn tired of everything right now.
Oh, I also wanted to emphasize, one of the great things about having psychiatrists work in neurology is because it sort of takes away the stigma of seeing a psychiatrist. Or I have patients who have never would have taken medications classified as like an antidepressant or classified as an antipsychotic, even if it is, helpful in a disease like Huntington's disease, where some of the medications that we have that we can use soonest are ones that are classified as antipsychotic because of the way they work in dopamine. So there is still that giant stigma, not just with movement disorders, but actually the realm of behavioral health and psychiatry. I think with therapists, it's because it's not like this threat of medications or, something like that, where the stigma, I think, is much higher. Again, it's often somebody else that can really help when that stigma is too high, or us embedded in neurology. They're like, well, no one's going to see that I saw a psychiatrist. So it's okay to get this treatment. It's okay to get this recommendation from them to see a therapist who will work with them and the neurologist, because then it's sort of enclosed in this realm of neurology that's somehow less scary. Although again, we're not very scary people.
Let's see. I think if there's anybody that has any questions, if you want to unmute yourself, we're probably close here to wrapping up. And I can't.
And then the last slide of the presentation, which you'll all have a copy of, is our contact information. Let me share that with you before we go. 1 second.
Now, we're at least in our health system, the only 2 psychiatrists that have this overlap with neurology and psychiatry, where we really work. We're dual departmented, I guess if that's a word. So that's why there's multiple ways to get a hold of us, like 2 separate phone numbers. But
you can always ask Julia. Julia knows how to get us in the middle of the night if she has to.
It's a little scary, actually. She has so much.
She'll find us. I mean, I'm serious, because she will find us, and we don't mind because again, there's only 2 of us. Nobody else does this in the state that we know of. We know that like there's partnerships with geriatric psychiatrists. There's geriatric psychiatrists kind of came from neurology because it's brain. It's more cerebral than some other psychiatry aspects are. We're basically born from neurology, so the neurologists work tightly with geriatric psychiatrists and vice versa, but I don't think there's any other embedded in the clinics like us. So I do it 2 days a week, she's in it 2 days a week. So we've got 4 days of the week covered.
Yeah, I think it's a great program. Of course, I'm biased, but would love to see more healthcare facilities do this and bring in this multidisciplinary component. Oftentimes they'll bring in allied health professionals, physical therapists, speech therapists. Obviously we need all of that. That's very important. But I think getting to the psychiatrist is something that sometimes can be a struggle for a lot of health systems. Obviously there's not enough of you. And also neuropsychologists as well. You know, we just did a topic, for those of you that are interested, the third Tuesday of each month at 7 o'clock, we do a virtual education series, and we just had Dr. Zek on, a neuropsychologist, that talked about the importance of getting a neuropsych eval, perhaps as a baseline, so that you can track changes over time. I think this is all very helpful information. Let's see. Well, lots of thank yous. Thank you.
I was going to say thank you to all who are listening to this, who are therapists, because we really appreciate working with you. We really appreciate any contact that's, you know, where we can be helpful to understand what's going on, because it cannot underscore enough that there's a shortage of therapists. You know, we all just keep retiring and aging out, and then COVID, and you know, it's not easy, and our jobs are not easy, and these are some of the most complex patients, complex illnesses that, you know, we come across. So I really thank all of you for being interested in being here.
And we appreciate your observations. So if you guys are seeing something in the clinic that we're not, or if you don't know, tell us, because you may be seeing a symptom that nobody else has caught yet because of how any of these changes can come on. So don't be shy about it. Reach out, let us know. You don't have to know what it is. You don't have to know how to take care of it. All you have to say is, I've noticed Mr. Jones is really struggling to get out of the chair lately. Or I've noticed that every time I try to get Mr. Jones to my office, he nearly falls. And then we'll ask you like questions about it, but that's enough for us to get started, to get them to where they need to go. So don't be shy about that. Because you see them more often than we do. You'll see them once a week, once every other week, once a month. We'll see them once a month, 6 weeks, 3 months, 6 months, you know, based on the med changes. So you'll see them more often than we will.
Before anybody goes, I did also want to mention that we've had a 7-series CME program at 7 a.m. on Thursdays. The last one is happening this Thursday at 7 a.m. And it is Dr. Cornelius Robins, who's a movement disorder neurologist, is going to speak about mental health issues and Parkinson's psychosis, hallucinations, anxiety, and depression. So it is the same link that you had for this program if you're interested in joining us bright and early at 7 a.m.
All right.
Thanks
well,
for
thank
having
you all,
us.
because I have to go. I think I have a 3 o'clock patient, but always nice to see everyone, or to meet new people. And thank you again for your attention.
Thank you.
Thanks for having us, Julia.
Thank you.